Good afternoon, everybody. And it's so encouraging to see that we have audience for the last session in the conference. Thank you so much. It is, hello, that's not working. I don't think this is working. This is not working. Hello? Yeah. So now I will invite on stage my esteemed co-instructors to please join me on the dais. Dr. Chandrima Pal, Dr. Arijit Mitra, Dr. Ganesh V. Raman, yes please, Dr. Siddharth Dikshit, Dr. Arijit Mitra. Please come and take your seat on the dais. Angle closure disease, yes, it is an old entity, but why do we need to go back and take fresh looks at this entity? Because this disease still continues to be responsible for 50% of blindness of world glaucoma patients. And there are new concepts coming up, there are new latest guidelines, newer diagnostic modalities, new tips and tricks regarding medical management, newer drugs, small tips in surgical management, which actually helps us to diagnose and treat PACD patients better and prevent some more blindness and give some sight years to some patients, which I think is the best gift that we can give somebody. So without wasting time, we will move ahead. My co-instructors do not need any introduction. Actually, they are all well known by their own rights, and I'm really privileged to have them in my course. Dr. Chandrima Pal is the current Secretary of Glaucoma Society of India, Director, BBI Foundation, Kolkata, and she is a well-known glaucoma practitioner in Eastern India for many years. Dr. Ganesh V. Raman is currently the Chief of Glaucoma Services at Arvind Eye Hospital, Coimbatore. He has vast experience in glaucoma, medical treatment, doing all types of surgery, training fellows, publishing, taking parts in studies, just name it, he is doing it all. Dr. Siddharth Dikshit is a young dynamic glaucoma specialist at VST Center of Glaucoma at LV Prasad Eye Institute. He is also the residency coordinator with special interest in angle closure diseases amidst all his other achievements. Dr. Shamashri Seal, Dr. Arijit Mitra are high volume surgeons and medical glaucoma specialists in Disha chain of hospitals, West Bengal. And I am Dr. Suchanda Sar. I am also a senior consultant working with Disha Eye Hospitals, West Bengal. Welcome everybody. And now we will move on to our first speaker, who is actually the last speaker, Dr. Chandrima Pal, but we will be having her talk first because she has to attend another session. So Dr. Chandrima will be talking to us about the surgical options in PACD. Dr. Chandrima, please.
Good afternoon, everybody, and thank you, Dr. Suchandra, for making me a part of your course. It is indeed a pleasure to be here with you this afternoon, and I'm sorry to, I think I'll have one microphone, it's very disturbing. Yeah, so I'm sorry to disrupt the flow, but it's actually totally unintentional. I have to go to the other hall as well, that's why. Okay, so I'm going to take you through the surgical options of, I would say, primary angle closure glaucoma, not really primary angle closure disease, because we generally are a little conservative and wouldn't really go for surgical procedure in primary angle closure disease. So that's our article, the Hooghly River Glaucoma Study, which clearly brought out that in the urban population, look at that figure out there, The ratio of primary open angle glaucoma is to primary angle closure glaucoma, and that's in the rural population. It's almost a 50-50 that you see out there, and it is actually more common than previously thought. And the indications for surgery are inadequate control of intraocular pressure with progression of optic nerve or visual field damage despite medical or laser treatment. Early lens extraction has been advocated, especially where there is significant cataract that is impairing vision. Mind you, the word cataract there is very important, not advocating clear lens extraction. So poor compliance or intolerance to medical treatment and inability to cooperate with laser treatment. So that's a study that was conducted by AIOS, of which I was a part, and this is the flowchart which they gave for primary angle closure glaucoma. But I'll move on to the surgical aspects straight away. So that's moderate visual loss that you see, PSCG with pass-on gonioscopy, inferior notching as you see out there. There's an inferior notch, and moderate visual field loss. And that's in eyes with severe visual field loss. And here what we consider generally a Faco trabeculectomy in the presence of a critically shallow anterior chamber with a thick lens or a high lens vault. These are the two important features that we do consider for surgery out here. And in eyes with total glaucomatous optic neuropathy and absent light perception, that's 270 degrees of cytophotocoagulation, cryotherapy, and we have also done the UCP, that is the ultrasound stereoplasty. So there are no objective values which can be used for this purpose. It's basically based on evidence from published literature. The consensus from AIOS, as I told you, expert meeting, said that a ACD of less than 2 millimeters and a lens thickness of more than 5 millimeters and a lens vault of more than 1 millimeter high may have a higher risk of complication post-trabeculectomy, and definitely a combined surgery should be advocated. Surgery in such cases is technically challenging and should be performed with as less interference as possible, and of course having a vitreoretinal surgeon by your side. So trabeculectomy is performed similarly as for open angle glaucoma. Use of antimetabolites is definitely advocated. Trabeculectomy either alone or in combination with lens extraction should be considered after an acute attack of angle closure if the IOP control remains suboptimal despite laser and medical therapy. In more advanced cases, angle closure glaucoma, which are already associated with peripheral anterior synechia, optic nerve or visual field damage, and in acutely inflamed eyes, trabeculectomy has been reported to have low success rates. Glaucoma drainage devices, well, in chronic angle closure glaucoma where trabeculectomy has failed to control the intraocular pressure, or in eyes that are deemed to be at high risk of failure from trabeculectomy. That's a study that we conducted and published, and it's the comparison of Faco emulsification versus Faco trabeculectomy in the treatment of patients with chronic angle closure glaucoma and concomitant cataract. And this is what we actually concluded, that patients at risk are those with a positive family history and other risk factors. And just to bring forward to you the modern day technology, that is the femtolaser assisted cataract surgery and trabeculectomy for angle closure. So precise programmable corneal incisions, accurate capsular axis shape and concentration, reduction in power and time with unique fragmentation systems, arcuate incisions, and less manipulation in an already crowded shallow anterior chamber. So flax is a surgery which you are, if you have it available, you can advocate if you're doing a Faco trabeculectomy. Filtration surgery in angle closure needs to be performed under peribulbar or single site injection of anesthesia. I generally do a single site injection, thicker superficial scleral flap, more than half thickness, tighter closure of the scleral flap, use of releasable tight sutures, and the AC should be formed by BSS or A at the table. So standardize your scleral flap, find the smooth plane of the sclera, fibers to be oriented uniformly, 60 to 75% depth, avoid cutting the sides of the flap too anteriorly. That prevents the side flow, and measure the size of the flap. My choice is generally 4 by 3 millimeters, 3 millimeter posterior to the proposed punch, just anterior to the scleral spur. That's how it is. Too anterior sclerotomy would give you a valve effect. Too posterior would cause iris prolapse. So it just has to be optimum. And of course, I always use the modified Weiss or the Condon closure, which makes a watertight closure. So a few things to keep in mind in this situation. Keep the surgery simple. Try not to actually handle tissue too much. Don't remove an asymptomatic cataract in a glaucoma patient just to reduce the pressure, because IOP lowering is not always very predictable on an individual basis. And secondly, cataract surgery is not without risk at all. So be prepared in case IOP increases, because decreasing IOP again would be a problem with steroids if the patient is a steroid responder, and talk to the patient be on the same plane. So I'll just show you a clip of, this is a femtolaser trabeculectomy. There's the docking of the LOI, and that's the, once it's docked and the vacuum rises, you have the live anterior segment OCT that you see, and that's the live anterior segment OCT where you can actually see what you're doing, and the adjustment of the capsular axis, and and once you press the foot switch, you have 10 seconds extra, Suchandra. So there you have the nucleus, which has been fragmented. I always prefer to do a 6 segment if I'm doing a trabeculectomy, because manipulation is less. Otherwise, I generally do a 4 segment nucleus fragmentation. You do a trabeculectomy normally as you would have done if you were doing a Faco trabeculectomy. Mitomycin, that's the way I apply it on a sponge, and the conjunctiva separated with the conjunctival separator that I designed, and of course wash it out. And the Moorfield safe surgery technique of trabeculectomy. So as I said, don't cut it right up to the limbus, leave space anteriorly. That helps in a larger surface area for the aqueous circulation. And then you move on to do your Faco emulsification. It's relatively easy when you have already fragmented the nucleus. Release the incision, that's the releasing of the femtolaser incision. Capsular axis just needs to be pulled out, and you just separate the pizza pieces with viscoelastic, and then just suck them out basically. So it's less manipulation in the anterior chamber, and that helps, of course, in angle closure. And once you've finished off with the cataract, the thing to note here is that not to take out your left hand so that there's less turbulence in the anterior chamber. Keep the left hand steady inside while you're doing the insertion of the lens, and also the cortical cleanup when you're removing your right hand. Then go back to your trabeculectomy and do your punching of the ostium as you would do in any other surgery. And it's advisable, of course, to give a releasable suture, but in this particular case, because the patient was leaving and couldn't probably come back for checkup very soon, so I just this is a releasable suture, but then you can also just give a normal suture. That's a releasable suture with 4 throws and the loop being dragged out of the, yeah, that's it basically. And then you close it, as I said, the modified Weiss or the Condon suture, where you have a watertight sealing of the two lips of the conjunctiva, and that's it. Thank you very much for your attention.
Thank you, Chandrima, for a very crisp presentation with take-home points within the slides. We will have to let Dr. Chandrima go to the other hall for her next commitment. Is there any question that anybody wants to ask her, or we shall proceed with the next talk and take up discussions later? Any question? Chandrima, do you do goniosynechiolysis in any of your cases? And if yes, then in what sort of cases?
No.
No?
I don't.
Dr. Ganesh, Dr. Siddharth, Orijit, any of you? Do you do goniosynechiolysis routinely in your...
I don't do goniosynechiolysis, we don't.
Siddharth? No.
No, so I had tried a few cases, and over a period of time I realized the synechia formed again. I don't know what is the cause. It's the pupillary block which is residual, or the nature of the iris is like that, so stopped doing after 2 cases.
Yes, that is what literature also says, that there is a concept that one should tap back the iris from the angle, try to open it up when one is doing a cataract surgery. And but it has usually been seen that either the pus reforms or there is no substantial difference in IOP control, even if you are not doing a goniosynechiolysis. Yes, Dr. Shumit Banerjee. Shumita, please.
Very good afternoon to you. And excellent presentation. One thing, what was the size of the scleral incision, and what was the size of the trabeculectomy size?
Basically, you mean the scleral flap?
The scleral flap, yes. It appears to be very small incision.
Yeah, so actually I've told you in my presentation as well. I'll just go back to that slide to show you that that is the best.
And what was the inner flap size?
You mean the ostium, punching out the ostium?
Yes.
Yeah. Oh, so punching out the ostium is basically, it depends on how much of the flow you want. So I generally do either 2 punches or 3 punches. That's it. And I use a very small trabeculectomy punch. I use a 0.75 trabeculectomy punch.
Okay.
Yeah.
And in this aspect, Shumita, without any financial interest, but we find that the Indo-German punches have very good quality. They do very crisp cuts.
Yes, Indo-German or Epsilon, either of the two. They're the best. Yeah. Thank you.
Just one more question, ma'am. Do you always do a twin site, or do you do a single site phaco trab also?
Always twin site.
Always twin site. Yeah. General consensus, do we all do twin sites now?
I have always done twin sites.
Yeah, I too agree. I do twin site unless very few open angle eyes in which I find that superior, I'll be able to comfortably get away with doing a single site. I will do a single site. It has to be open angle for me. Very rarely, mainly because of the logistics of the theatre. I don't want the machine to come around, and I wouldn't want to sit on the other side and operate. But very few, almost 95% I'll do twin site.
Yeah, even I do twin sites, but I gather Dr. Ganesh does a superior trab and temporal phaco all the time, that he means twin sites, but I do twin sites superiorly also, doing a nasal trab and a temporal, slightly temporal phaco, but sitting superiorly. Chandrima, your twin sites are also superior.
My twin sites are superior trabs, and the phaco is temporal, maybe at not really 9 o'clock, but maybe at 10 o'clock or so. Yeah, where I can just actually extend my hand and do it without changing my position. Yeah. Thank you. Thank you very much.
I will invite Dr. Shamashri Seal to come and talk on her topics and give us an insight about the newer mechanisms that have now been understood about angle closure and their clinical relevance. Dr. Shamashri, please.
Good afternoon, everyone. I thank Dr. Sar for giving me the opportunity to speak at this forum. Now, just talking about mechanisms of angle closure and its relevance in clinical practice. Thank you. It's working. Just shortly going to the epidemiology, we know glaucoma worldwide is 76 million for 2020 figure, and in Asia itself, open angle glaucoma is 53.4%, whereas angle closure stands at 76.7%. And in India itself, 12 million people are affected with glaucoma, among which 1.2 million are already blind. Now coming to what is primary angle closure, or what is we call is primary angle closure disease. It is the presence of iridotrabecular contact. This contact may be either appositional or synachial, which can be differentiated by indentation gonioscopy or by manipulation of the angle. This is just a schematic diagram which shows the normal aqueous flow from the ciliary body to the anterior chamber to trabecular meshwork, and when there is an angle closure, there is a blockage and the aqueous cannot flow freely. And as we all know, we can identify the angle only by gonioscopy, which is the gold standard. My next speaker is going to speak on it, so I'm not going into details. The second most important thing is that when we are doing a clinical examination, anterior chamber examination is very important when we have to do the Van Herrick's, and we have to compare the anterior chamber depth with the corneal optic section, and we have to grade it from 0 to 4. Now, according to ISGEO classification, primary angle closure is basically now divided into primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. Now, in primary angle closure suspect, what we used to see is there's 270-degree iridotrabecular contact, but it has been seen there have been presence of PAS, and there may be lesser degree of contact. So now the cutoff has been taken as 180 degree to consider it to be a primary angle closure suspect. What is primary angle closure is when there is total trabecular meshwork obstruction and there are associated features like increased IOP, there is glaucoma flecken, lens opacities, excess pigmentation of the trabecular meshwork, but the main difference is there is no optic disc damage. And in primary angle closure glaucoma, along with PSC features, we have noticed glaucomatous optic neuropathy, which can be corroborated with visual field changes as of glaucoma. Now, a patient may present to us either in an acute stage or in a chronic stage. When he comes to an acute stage, it's easier for us to identify the patient as he has symptoms along with elevated IOP. This occurs mainly due to quick and complete obstruction of the trabecular meshwork. If this is not treated, it may move to chronic stage. And in chronic stage, the symptoms are much lesser as the meshwork gets closed up slowly, and there's PAS formation which may be unicentric or multicentric. And as the patient gets times to accommodate to the elevated IOP, the patient does not come with much of symptoms, and we can see there is zippering up of the angle. Now coming to the pathogenesis of angle closure. The newer imaging techniques such as anterior segment OCT and UBM has helped us to look at angle closure in a newer look. Two mechanisms have been considered. First, crowded anterior chamber and narrow anterior chamber angle. This has been a very common feature where there is obstruction of the normal aqueous when there is bowing of the iris and pupillary block. This is a swept source OCT which is showing a normal angle where we can see the scleral spur and trabecular meshwork, but when the angle is getting closed, we cannot view these features. Now coming to the crowded anterior chamber, the ASOCT has given a new focus to the whole anterior chamber angle. What happened? We can now identify the features like small corneal diameter, shallow anterior chamber depth, along with small anterior chamber area and volume. The lens plays an important role, the lens thickness, its anterior position, its lens volume. This all adds up to crowd the anterior chamber. A short axial length lesser than 21 millimeter, especially seen in nanophthalmic patient, is a very big risk factor. Along with this, we can see anteriorly rotated ciliary body, greater iris volume, larger iris curvature, and we have seen that in patients with their increasing age, there is increase in the thickness of the lens, and so PSEG is more common in ages above 40 years. This is just a schematic diagram showing a normal open angle, and there is crowding of the anterior chamber because of the increase in the lens thickness, volume, and there's bowing of iris and rotation of ciliary body. To sum up all these pathogenic factors, we can start at the genetics, which starts at our body with the anatomical features of crowding of the angle, the iris changes, the lens changes with uveal expansion, and certain living habits, mood, weather, other features, and with increasing age, we land up in a PACG. Now this PACG may occur by two mechanisms, as we know, by pupillary block or non-pupillary block. Pupillary block occurs when there is a proximity between the lens and the posterior surface of the iris. It generates a pressure between the anterior chamber and the posterior chamber and forces the peripheral iris to bow anteriorly and causes a pupillary block. But in a non-pupillary block, mainly the iris plays an important factor. There is thick peripheral iris, anteriorly located peripheral iris, anteriorly rotated ciliary body, and plateau iris. As we know, this is an entity which plays an important role in angle closure. What happens in this, we can see in the UVM picture, there is iridocorneal contact, there is anteriorly rotated ciliary body, there is angulation of the iris, and absent ciliary sulcus. This can be seen gonioscopically as double hem pattern or sine wave sign. Now, we have to stage this condition when the patient presents to us. We have to identify the patient because our treatment protocol will depend on the stage he presents to us. It may present to us in a preclinical stage. When we are doing a routine gonioscopy, we see there are occludable angles. We have to treat them accordingly. Or in cases in which the patient had undergone an acute attack, the other eye is susceptible to angle closure. They may present as acute attack. This attack may be mild, where there are small spikes in IOP, and patient may see colored halos, cloudy vision, mild eye congestion, and this occurs mainly due to incomplete angle closure. Acute attack is more easily identifiable because of sudden rise of IOP, which may be above 70 mm of Hg. Patient typically presents with intense eye pain. There is nausea, vomiting, conjunctival hyperemia, corneal edema, mid-dilated pupil, along with flat anterior chamber, and we can see the typical triple sign where there is pigmented precipitates, irregular iris atrophy, and glaucoma flecken. Certain patient comes with intermittent stage where after an acute attack, which may be mild or acute, the half of the angle opens up. But he is in a dangerous condition because he may go into acute attack at any point of time. Chronic stage is a stage where the IOP has progressively elevated. It has caused significant optic nerve damage, and this occurs because of more than half closure of the angle. An absolute stage or the end stage is when the eyeball loses visual function, usually with refractory eye pain. This is how a patient passes from preclinical stage to acute stage, which may be mild attack or acute attack, to intermittent stage, chronic attack, and an absolute stage. Now, there are certain clinical conditions which may predispose a patient to angle closure, like a pupillary dilatation at outdoor examination may cause a iris and choroid to effusion, and that may lead to angle closure. And certain drugs have been found to cause choroidal effusion, like bronchodilators, SSRI, TCA, muscle relaxants, and antiepileptics. So our take-home message is doing a proper clinical examination to identify the stage that the patient may go into a primary angle closure is important, and for that gonioscopy is a very essential and must, along with the antechamber assessment, which may be helped out with newer imaging techniques, assessment of the stage in which the patient presents to us, so that we can intervene at the proper time and can prevent the patient from going from PACS to PACG, and thus a regular follow-up is needed so that the patient does not end in blindness. Thank you.
Thank you, Dr. Shamashri. for a very comprehensive presentation regarding the causes of pupillary block and non-pupillary block mechanisms of angle closure diseases. Because normally angle closure diseases, we used to only think that pupillary block is the only way that it is happening. And nowadays there is a lot of focus on crowded anterior chambers attributed by the iris, the lens, the ciliary body, and the corneal measurements. Everything has a role to play in PACD, and it varies from patient to patient. And if we can detect them correctly, then we can treat them in a more focused manner. So our next talk by Dr. Siddharth will be about the angle status. That is the most important in these PACD diseases. What is the status? How to diagnose from a general ophthalmologist point of view? How do we diagnose it in our regular practice? What are the points to look into? And meanwhile, any questions that anybody who has, where we can discuss while Dr. Siddharth takes over. In your experience of glaucoma practice for so many years, what would you attribute, how many cases, what would your percentage of PACD cases be in your regular practice?
I think we see about almost 50% angle closure disease in our practice.
Yes, and what would you think is the major contributing factor in all the cases that you're seeing?
We did the iFace study. It's a series of 10 publications, which is family screening and diagnosis of angle closure in siblings of patients with, we have about 900 patients in all the groups put together. So we found that each patient with angle closure, if you analyze the sibling, 1/3 will have open angle, 1/3 will have a PACS, and 1/3 will have PAC, PACG. So that's how I think most of it is related to genetics. That's what I strongly feel.
Yeah. The study Ganesh sir is referring to is using ASOCT and multiple centers. So the data is pretty compelling. However, recently I was very surprised that there was a publication by Dr. Friedman's group where they stated that we are probably overdoing PIs. So there was a recent publication, but you have to take it with a pinch of salt because, as Ganesh sir was mentioning, nearly 50% of the cases we see are PACD cases. So definitely in India, the scenario is very different. A lot of the cases are PACD cases. So a proper gonioscopy is a must.
And nobody talks about overdoing cataracts.
The other thing is, for example, a PACS patient, if you say that you don't want to do PI, that's fine, that's very good. But you must understand, as the patient increases in age, they may develop other comorbid conditions like systemic hypertension, hypercholesterolemia, and diabetes, which will cause microvascular changes, and the intermittent angle closure causes them to go in for vein occlusions and other retinal complications. So you have pressure fluctuation from the ocular side, you have pressure fluctuation from the systemic side, and then leads to ocular. So if you have a risk profile of a patient who has systemic comorbid condition and also suffering a PACS, I personally would do a PI.
This is a very important point that Dr. Ganesh has brought up, because I was in another forum a couple of months ago where somebody cited the ZAP trial. It is a randomized controlled trial done in China, the junction angle closure prevention trial, in which they have said that in about 44 patients, if they are PACS patients, one would go into PAC if YAG-PI was not done in these cases. But so do we do a YAG-PI in occludable cases or we don't? That I think we will talk down the line. We will take it up again.
Right. Thank you, Dr. Suchanda, for making me a part of this course. Very interesting discussions have happened and we are looking forward to more. I'm going to talk about I'm going to talk about understanding the angle, if the presentation moves forward, and about 3 different ways that you can look at the angle. And these are the 3 things that we need to look at. from a point of a clinician and how useful these things can be at different setups. So there is no doubt in our mind, and there should be no doubt in anyone's mind, that for management of glaucoma, gonioscopy has got no replacement. So who needs gonioscopy? So any person who has glaucoma of any etiology that is presumed needs a gonioscopy, because the most common misdiagnosis that happens in glaucoma clinics and in ophthalmology clinics is NTG being diagnosed, whereas the patient actually has angle closure. And when a gonioscopy is repeated later on, around 20% of patients may turn out to have an angle closure disease. Apart from that, patients who look normal but have risk factors for glaucoma or have a shallow anterior chamber, a Van Herrick's done very carefully right at the most peripheral part of the limbus, with the angle between the illumination and the housing viewing arm being 60 degrees, will pick up most of the patients with angle closure and other indications. Also, we need to repeat gonioscopy. Repeat gonioscopy, why? Because angles do become narrower over time, and that growth of the lens is different between different people. So you may see patients with open angle going into a slight closure over time. It's not rare. All patients with raised intraocular pressure post dilatation should undergo a gonioscopy again. We all have, and especially when we trust on other people to do the gonioscopy in our clinics, it may happen that they may not have had the experience, or the room light might have been on where an angle closure was missed. And any unexpected events, raised intraocular pressure in a patient who is well controlled, progression with normal IOPs, these should be the red flags where you repeat a gonioscopy. Post trabeculectomy and prior to needling, when you suspect a block at the ostium and need to rule it out, you need to go do a gonioscopy. Now, this is a very famous image, and I'm quite sure everyone knows about it. But what we need to understand is a 4-mirror is not the best lens to get a good view from a in situ position. So it is the golden one that you see here, that is the Goldman. It should not be the 3-mirror, it should be the, okay. It is actually the 3-mirror, which has the best view in situ. But it is the capability to perform indentation which gives the 4-mirror a superiority over not the other gonio lenses but any other imaging technology, none of which can have this capacity. So a 4-mirror lens is an essential part of management of glaucoma. And it was thought that it was difficult to do, but most residents and fellows, when they start with a 4-mirror, they actually pick up. It's not different. I was brought up on a setup when we did 2-mirror for 6 months, then bought 4-mirror. It's not necessary to actually climb that ladder. So what are the structures that you see in an open angle? This is a very typical lightly pigmented open angle, and what you see here is 3 pigmented lines. So when you see 3 pigmented lines, you can almost assume that this is an open angle. And I'll just pause it here. Okay. The video may be too long. I'll just pause it here. Okay. So that was the iris. This is the ciliary body band. Then you see the white line above it. That's the scleral spur, followed by the posterior trabecular meshwork, the anterior trabecular meshwork, which is the home of the trabecular meshwork stem cells, and the irregular pigmentation. The difference between pigmentation of that is anterior to the trabecular meshwork at the Schwalbe's line and the posterior trabecular meshwork is the lack of uniformity of pigmentation and width. So Schwalbe's line will have differentiation in both. Neither will it be uniform in extent or depth, extent of pigmentation, nor the width. Now, one thing that we all have to be really careful. Now, what you see in this angle is 3 pigmented lines. Easy to get tricked that this is an open angle. So, never not indent. Okay? It's like having the 5th gear in the car but always driving it in 3rd gear. We don't do that, right? So, always indent, and you will find surprises that the 3 pigmented lines or 2 pigmented lines that we assumed that was the Schwalbe's line and the PTM turn out to be multiple pigmented lines ahead of the anterior trabecular meshwork. So always do indent, because these are the worst kind of patients with angle closure. So this is something that we must rule out. One very important thing is the sequence of performing gonioscopy. So we all know that the role that gonioscopy has, most importantly, is to rule out occludability and angle closure. And with a 2 mirror, with help of manipulation or over the hill technique, you can rule out and differentiate between an open angle and occludable angle. And with a 4 mirror, you can also have differentiate between a synechial angle closure. But you don't stop here. You don't stop here. Once you have ruled that out, increase the illumination, increase the width, and then look at the angle, because it's not the only thing that you need to look at. You also need to look at the structures in the angle, and that is how you can look at the ostium, the new vessels, the iris processes, if you don't stop there. So don't stop there. I will go a little fast now. So there are 3 things that OCT can look at and looks at very well. It's the lens-based parameters, basically the lens vault. Then there are parameters which are based on identification of the scleral spur, which you see as seen here on this OCT that was performed on. Come on. Okay, I have a blackout. Not Visante, this is the new one.
Anterior.
Not? Cassia, right. Sorry. So, brain freeze. Okay. And then you have, based on that, the angle parameters like the angle opening distance, the trabecular iris space area, but what is most important is the angle recess area that you can see here. So, this not only gives you the width of the angle, but also the part of the angle that is critically narrow in patients with plateau iris. So this is a very important parameter that you can look at. Now, do not use ASOCT to diagnose angle closure. You can of course do it in a patient where you have suspicion, but diagnosis should not be based on that, because it is very easy to falsely open the angle with the illumination that is happening in the room, or the patient accommodating because the target is a little close. So it is possible that you miss borderline occludable angles, but the only use I think we would have is to see in borderline cases if there is a worsening of these parameters over time, and do a PI in a patient with PACS if that may be required, and to look at the lens vault in managing the glaucomas. A very exciting and a fresh phase that is coming up is the gonio imaging or direct visualization. So these are a few things that I will just share a few images. The GS1 by Nidec, which gives you excellent images, and it can stitch the images automatically and give you a goniogram that you can have here. Amazingly, this is an image from a RET cam in a patient with congenital glaucoma, and I don't think there can be a better view. You can do the same with a nasal endoscope. And this is the most amazing technology. This is something that has been developed by the Singapore Eye Research Institute. This is called the Gonio Pen. And this gives you the only chance that you can take an instrument to a village, screen the entire population using this pen, while you as an expert sit in your big city, look at the angles and say the individual number A, individual number Z, they are the ones who have occludable angles, get them here. And the greatest thing is, if you look at the comparative quality of the images, Gonio Pen is not doing bad. It gives you excellent images. Sometimes there can be, as I hear, an image that is not good, but on repeating you usually get a good image. So I think there are exciting times ahead, and we will have a fresh look when we have this device in our hands. Thank you.
Any questions to Dr. Siddharth? Because I think which lens to buy, how to start doing gonioscopy. Is it the 3 mirror? Is it the 4 mirror? And since he is an institute like LV Prasad, where they are in teaching mode every day, in and out, he is the best person to talk about these and which lens to buy. And I would, before we proceed further, Siddharth, I would like you to please show us how to identify the scleral spar in a anterior segment imaging, because our technicians often come to us and tell us where should we measure the angle from. So I saw one of your slides has the SS marked out.
So the great thing about the newer devices is that they actually pick up the scleral spur automatically, but you need to have a check. They may do a false detection, and it's basically the junction between the gray and the moment you start seeing the white line there, which should, can we have the last presentation once? The problem with the older generation machines like Visante was that the rate of detection of the scleral spur was very low. We could not do it well in most of the patients. But the modern generation...
I just have a question, Dr. Siddharth here.
Yeah.
Like as we theoretically read that there is a wedge, like there is a protrusion, when we follow where the cornea ends and the sclera starts, there is a spar. Is it really you can understand, or you just try to have a...
No,
that is true. We can create that parallelopiped image, and we can you can have the arc, and you can high resolution. For example, if you use a Zeiss slit lamp with a 32x magnification, you can really pick it up very well. The 8 and 16x, you won't have that clarity, but you can do it best with your YAG machine. Your YAG machine optics are far superior than your slit lamp machine optics. So if you use it,
they give a better
they have better magnification. You don't use it so much. It's much better maintained. It's not so frequently used. Because of a laser, the optics have to be far superior than your slit lamp, because the laser cannot be distorted. So YAG machine slit lamps, if you want to see a parallelopiped, always do it on your YAG machine. The optics are far superior.
I'm not talking about the
I think Ganesh sir is talking about the parallelopiped and the wedge.
No. I am not talking about the wedge.
Sir is asking ASOCT.
ASOCT is that area as we see.
Yeah,
like
I'll just add to it. The thing is, if you look at the raw images, which we normally see or show in these, it's very difficult to identify it. Problem is that you need a software to process these images. Once you have 10 or 15 images and the processed image, you will definitely be able to identify it. So in the study that Ganesh sir was mentioning, the iFace study, we did not look at one single image. There was a software which used processed image, and there you could definitely see the change in color.
So coming back to each scan is multiple times taken, and then
AI
you get
driven, no? There is AI driven, I think, no?
Not exactly. It says algorithm driven. It says algorithm inside the software, in which you have to have the software to detect scleral spurs separately installed. It doesn't come bundled with the machine.
For Cassia, I think it's a very expensive machine, and I don't know, very few people can actually have it.
It did that, what happened? I don't know. So you can see the junction of the inner margin and the where you get this white thing starting, that's the scleral spur.
So by definition, it will be the highly refractile structure seen on UBM or ASOCT. It has to be extremely high refractile. So, softwares can make a mistake. So, anatomically, we also should be very clear about it.
Like we were mentioning, this particular image, it may be very difficult to identify. So, probably looking at it, people can get confused. But if you take multiple images of this particular and use a software, you will be able to see that refractile change. And manually also you can change it. Even though the machine can be faulty, you can still drag it around.
That is critical, because based on that, all these quantities...
Everything is dependent on that.
Yeah, dependent on that.
Thank you, Siddharth, for updating us our knowledge.
Ma'am, one second. Regarding the 2-mirror and the 4-mirror, because Siddharth is in a teaching institute now.
No, look, when I was in Vellore, we were made to do 2-mirror gonioscopies for about 6 months. We were not made to buy both. That was from the institute, and actually it was very helpful. So my firm belief was that you should start with a 2-mirror, start looking and identifying the angles, and then move to 4-mirror. But then when I came to LVP at Hyderabad, everybody was doing 4-mirror right from the beginning, and it didn't make a difference. So you don't have to learn to ride a 2-wheeler before a 4-wheeler. You can actually start directly with the 4-wheeler.
And seeing your Gonio images, I think the red cam gives the best image.
Red cam, very, very good images using a red cam.
So we use red cam sometimes, and even the nasal endoscopes, and you can't believe the quality of images that they have, but you can't use it every day in the clinic, and they require illumination. That's the problem. So for photography they are excellent, but for ruling out an occludable angle, you can't use that.
So not very clinically relevant. For documentation, they are good.
Yeah, because it requires a good illumination. It will constrict the pupil.
Okay.
And in case anybody is having doubts about buying a 4-mirror, you can buy a 2-mirror called an NMR Kapitansky lens. It's a 2-mirror lens. NMR stands for no methyl cellulose required. That means the curvature is such that you don't need to add any viscoelastic. So it's a 2-mirror without viscoelastic. So you can, it will be easier to shift from 2 to 4-mirror. So these are also available from Ocular. So you can buy that and start using it and then go on to 4-mirror.
But from experience, a 4-mirror, don't be scared of a 4-mirror. It just takes, I think, just a matter of week or so that you will get used to it and you will be able to handle it. Isn't that so?
Absolutely. Like we were told, you have to learn ECC, then SICS, and then Faco. But now everybody is learning Faco first. So you can learn Faco first without learning ECC or SICS also.
So I want to ask one thing. With the red cam or here, with the red cam or that nasal endoscope you told, so you require any special lens along with that, or directly you can do the imaging?
No, you just put it on the eye over a blob of viscoelastic.
Okay. Thank you.
LPI, iridoplasty, SLT. Each has its own specific role in PACD, which helps us to manage the patient better. Dr. Ganesh will give us his talk on this topic.
Thank you, madam. Thank you, madam, for inviting me here, and thanks to the Chairman Scientific Committee for providing me this opportunity to speak to you on laser iridotomy, plasty, and selective laser trabeculoplasty, when and why. So laser iridotomy, as we have been speaking about it, it's mainly for pupillary block and for certain other conditions which have angle closure, pathogenesis, and other conditions like secondary angle closure. So this is a very important procedure. We do it day in and day out. And the indications include iris bombay because of the angle closure component, hyperopic eyes, short axial length, shallow chamber. And these are all the applications of the laser procedure. And what it actually does, it relieves pupillary blocks. You can see a patent iridotomy in which you can see the red glow on retroillumination, and also see in high magnification the clear anti-lens capsule when it is patent. So therapeutic indications include primary angle closure, glaucoma and disease, primary angle closure, and pupillary block in pseudophakic eyes, acute angle closure after control of the intraocular pressure medically to reduce corneal edema and inflammation. And you must always do it for fellow eyes who have suffered acute attack in the other eye. Narrow angles in diabetics and retinal pathology eyes will require frequent dilatation. And if the intraocular pressure is elevated, and of course naturally in angle closure with dilatation, nanophthalmos, fellow eyes of malignant glaucoma. So these are all the prophylactic indications. So the technique is you use topical anesthesia, use the Abrams contact lens, search for a crypt in the periphery of the iris, and better always either in the 11 o'clock or the 1 o'clock hour. Contact lens, the advantage is that stabilizes and the eye and acts like a speculum also, and the peripheral view is magnified, and it maximizes the laser delivery at a required spot with the plus 66D button. So corneal, it reduces the laser effect on the cornea by 1/4, whereas it increases the effect on the iris by double that time, double the quantity. So pre-treatment we use pilocarpine, 2% to constrict the pupil, and apraclonidine. If you don't have apraclonidine, you can use brimonidine, so which is about half an hour before the procedure and immediately after the procedure. So this is how we do the procedure. You have the aiming beam, which is actually the helium neon beam, which is red in color, and then it focuses on the site. This is of course being done without the lens, but always recommendation is to do it with the lens. For photography purposes, we're doing it without the lens. The energy is 6 to 8 millijoules, 1 to 3 pulses per application, 1 to 6 shots. So if it's you can use less energy. Sometimes we use even up to less than 2. Because that's all is required. 6 is really little high, but some thick irises you may require such a scenario. And how do you identify it is that there's a sudden gush of aqueous from the posterior chamber to the anterior chamber. It brings along the debris. And if you don't see the sudden gush of aqueous, you would notice this when you're doing, for example, before the ICLs were there, we used to do LPI for myopes. So you won't find that gush mainly because there's no relative pupillary block. It's like shooting at a curtain which is not very taut. So if you don't see the gush of fluid, that means reconsider your diagnosis very quickly. And the anterior chamber deepens. You can always do gonioscopy immediately after the procedures to see what your laser has attributed and how much your angles have opened up. So that's the best time to see the angle, and you can identify all the structures because you have pilocarpine effect and it's pulling the iris very tautly to the pupil very tautly, and you can see the gonio findings very quickly. And this is part of the I-phase study which I mentioned previously. So what are the situations in which you don't get a very good opening of the angle of the anterior chamber? So one is the gonioscopic width. If it's very narrow, then you can get a very open angle. Number 2 is increase CDR. So if you have a patient who has angle closure disease and you find that the vertical CD ratio is slightly on the higher side, be very careful. You may not be able to open the angle very well in those eyes. So these are certain factors which can guide you whether you're going to open the angle thoroughly or not. And coming to the argon laser iodotomy, this is again something which is useful because now we don't have pilocarpine. It's now recently become available. For last 3 months we didn't have it. So some of the patients we are managing with argon laser iodotomy, you don't have to really penetrate the iris. You can make a burn in the iris and then use a YAG laser to hit on the burnt area on the eschar so that you can open the iris and make iridotomy. So coming to selective laser like trabeculoplasty, Mark Latina in the year 2000 developed this, and the advantage of this is that it has a very large spot size but with very minimal injury to the trabecular meshwork, and the duration of energy delivery is only 2 to 3 nanoseconds. Unlike photodisruptive laser, which is YAG, which delivers for more than 100 milliseconds. So this is very brief, and this is a study in which they had successful ALT performed and also unsuccessful ALT, and then they treated the ALT treated eyes with SLT, and you find that with that both the groups attained at 1 year they had a very good intraocular pressure control. So SLT done after ALT was also quite successful. So this is how the picture which has been published looks like. So this is on the left side is your ALT and on your right side is your SLT. So there's no damage to the trabecular meshwork which can be visualized when you do histologic studies. So mechanism is by selective thermolysis by ultra short laser pulse, and helps to generate and confine the heat at a specific target site, which is the melanin, and it releases certain chemotactic factors and recruits macrophages, which affects the aqueous outflow. So important thing is to do a good gonioscopy. This is not recommended for angle closure. So you must, as Dr. Siddharth has pointed out, if you are seeing an open angle, you must see a little bit of ciliary body band and then perform the procedure. If the ciliary body band is not seen, you are slightly anterior, the anatomy is not normal, it could be a developmental change. So those cases don't respond very well. Treatment naive patients are very, I'll show you some data about that. And in our center, we were doing this, we would stop all glaucoma medications, particularly after doing the procedure, if possible, even before doing the procedure. You may get a delayed response, so you may get the effect after about 4 months also. So you have to handhold those patients for about 2 to 3 months, and then give intermittent glaucoma medications, oral or topical, and then make sure that, okay, can we move forward? 2 minutes? Okay. So these are the baseline data for results. We had about 130 eyes, and if you look at the intraocular pressure in the third column is the ocular hypertension. At the end of 1 year, it was 17 millimeters of mercury, and POAG patients, it was 16 millimeters of mercury. On many of these patients were not on treatment. Number of glaucoma medications was also pretty less, 0.22 in the total group. And treatment naive patients were 6 in the POAG group. So at the end of 1 year, they had an intraocular pressure of 14 millimeters of mercury, whereas ocular hypertensives and POAG who were over-treated 17 and 16 millimeters of mercury. So in treatment naive eyes, there's only 6 patients in that group, but they did really well at the end of 1 year. So most important factor for success was intraocular pressure. So you should have slightly more intraocular pressure when you do this rather than lower intraocular pressure. So this is part of the second study which we're doing. Just wanted to highlight that good gonioscopy is very, very important. So coming to iridoplasty, this is again an important procedure, but as of late we are not doing it so much. The indications are that you can do it micro-ophthalmic, nano-ophthalmic eyes, and plateau-iris syndrome. And this is how the spots look like. You laser the periphery of the iris so as to pull the iris away from the angle of the antechamber. There are a lot of, there's a very good Cochrane review of this, whether LPI followed by iridoplasty is useful or as a primary procedure or sequential. But as of now, there's not good evidence to say that iridoplasty is more beneficial compared to medical treatment. Thank you very much.
Thank you, Dr. Ganesh, for a very nice talk, informative. You said that one of the indications for LPI was malignant glaucoma in the other eye. So if we get malignant glaucoma in one eye post-operative, do we do a PI in the other eye?
No, only indication is if you have, because malignant glaucoma is usually associated with angle closure which has been missed. That's one, or sudden shallowing of the chamber while doing surgery. Okay. So that's 2 things, and it doesn't happen very commonly, but you have to keep an eye and make sure that the other eye doesn't follow the same result. So if it's angle closure, then better to do a PI in the other eye. Malignant glaucoma is just a indication that there's something wrong with the other eye.
And in Disha, we do not have SLT, but this is a question that I have been asked by ophthalmology specialists who are planning whether they should buy an SLT or not, regarding how effective is it. So what should be the answer?
So I think the Shankar Netralaya group have a SLT, and I asked the same question to Vijaya madam, and she said that they have a duet machine which works on the Q switch laser. So the YAG procedures cross-subsidize the SLT. So it is an expensive device. It's about 45 lakhs and so if you use the YAG machine for your your YAG procedures, your capsulotomy and your idiotomy, then you have a chance of cross-subsidizing that because the duet machine switches both between the SLT as well as the YAG. So you just have to flick a switch. So you work on the YAG, and then once you want to do SLT, you work on. So that's how they are cross-subsidizing the cost of the machine to take care of both the patients. But
SLT per se, you would not promote to be a very effective tool for management of?
No, it's very effective. Our data shows that most of the ocular hypertensives, some of the ocular hypertensives, we have done SLT and the pressure of 44, just giving them Diagnose half an hour, 1 hour before the procedure. And they're doing well. About 2 years, 3 years down the line, they still do very well. So since that is one, it's a very useful tool. Okay. We've been having it, and we are again talk with the Zeiss team for the new SLT which has come. Okay. So it's a very useful tool for management of open angle glaucoma in young patients. Our mean age was 47 years. So SLT, everybody would try to use it at the age of 60, 65 when the patient comes to you at such a stage. That's not the correct patient profile for doing the SLT procedure. Even our POAG patients were young patients. They were not very, we were able to reduce the medicine drastically.
And I think also in pregnancy, SLT has a very big role.
One of the case reports which I had mentioned was glaucoma in aphakia with ectopia lentis. She did very well. We were able to reduce the medicine after the SLT. Siddharth wants to say something.
Dr. Siddharth, are you doing SLT at LVPA?
We had a demo machine also tried for quite a bit, and we were trying to work out the economics of it. But before that, I was just wondering, JOAG is supposed to be a situation where in at least the white eyes, the SLT doesn't work that well, isn't it? It's different.
In our eyes, we didn't include any patient with JOAG. We had only patients POAG above the age of 40. Our mean age was 47. So we never included any patient less than 40 years of age. JOAG, from my perspective, is a surgical disease and attributable to the trabecular meshwork directly. Whereas open angle glaucoma, which is starting off, if you catch them early, if they're on 2 medications, and then you can do SLT, you can save the number of years. They don't have to go with drops.
And Ganesh, are you doing 180 degree or
360
at one go?
One go in one eye, and 2 weeks later the other eye.
2 weeks later the other. And what is your incidence of repeatation of the procedure? We have
10% failure rate. So failure rate means going back to the baseline. That means if you see them at 30 pressures, they'll go back to 30. So that's a possibility, and that is where gonioscopy is very, very important. Because everybody does the gonioscopy and everybody detects glaucoma and everybody treats it. But the crux of the matter is that, as Dr. Siddharth mentioned, you must see a sliver of ciliary body band to do SLT. If you don't see the ciliary body band, if your iris is anteriorly inserted, please don't do SLT. They are all little abnormal angles, which I feel they are not conducive for this procedure.
Thank you for this very important tip. And now Dr. Arijit Mitra, role of medical treatment, right from pilocarpine to PG analogs. I think Dr. Dipanjan has a question.
Yeah, why do you think that the comparatively younger people, the effect is better?
So I think, the time they start getting the raised intraocular pressure, it's genetically defined, I think, because if you see the profile, and later on, once you start treating them, there are some old literature which says that the inner wall and the outer wall of the Schlemm's canal, they sort of, the Schlemm's canal collapses, and the inner wall sort of invaginates even into the connector channels. So you really cannot cleave, even if you do a GAT procedure, or if you do SLT, or if you put eye stent or any of these mixed devices, you may not be able to cleave the inner wall, and there's no space there. So because of this, we feel that the elderly population, they respond in a different way compared to the younger population. They have just started off in their glaucoma life, so to say, and this will, I don't know how, but this helps them in that particular age group rather than the older age group. Older age group, they don't respond so well.
Yes, sir.
Excuse me, in patient of ITP who requires a peripheral idiotomy, you will prefer which laser, Argonne or YAG?
Sorry, sir, patient of?
ITP, idiopathic thrombocytopenia.
Yeah. So patients on clopidogrel, dipyridamole and all will do Argonne laser, and then char the area of, and then do a shot with the edge of the S-char and the iris tissue. So you cannot shoot the S-char directly, it won't rupture, but you have to be right at the edge.
That's a very important question, because this is also very much confusion whether to stop blood thinners before PI or not. So you routinely do Argonne laser?
We do routinely Argonne laser, and supposing the patient has seen his cardiologist, let's say 1 year back, he goes for a visit only once in a year or once in 1.5 years time. They don't have to see the cardiologist every year if they're normal. We ask them to get a cardiologist's opinion and come back and then do the procedure. We're very particular about that. There are some fainting attacks, they develop vasovagal syncope, a lot of issues can happen. So we're very particular that they get a cardiologist's opinion before the laser.
No, but you don't stop the blood thinners.
Blood thinners, we take their opinion. If they say they stop for 5 days, 10 days, then we take it. If they say that, okay, it cannot be stopped, we have to shift to heparin. For example, we do low dose heparin subcutaneously and then do the procedure. Make sure the INR is within that range.
Even Siddharth and LV Prasad, you are that.
We don't stop the blood thinners. There are people with known blood diastasis with bleeding disorders and all. There we do a sequential PI as Dr. Ganesh does, but otherwise we
Same
don't.
Day sequential?
Same day sequential, yeah.
Sir, and I saw your video doing the YAG without the lens. So in event of bleeding, how will you stop the bleeding if it bleeds?
That was, so you just pinch the upper lid and lower lid together and increase the intraocular pressure in the eye.
And the Argonne laser does not require a lens?
It requires a lens, same Idiotomy lens. Yeah.
I do PI with the use of a lens, but my mentor, Dr. Ramakrishnan, has always done it without lenses. No bleeding. I don't know how it happens. He's never used a lens.
Yes, sir, your question.
Madam, what would be the rationale for a prophylactic iridotomy in a non-pupillary block angle closure?
No rationale.
What's the rationale? How does it help?
No,
because if there's no pupillary block,
iridotomy
it does.
Yeah. So according to the Riches classification, there are 4 levels of angle closure. One of them is the anterior pulling mechanism where there is no pupillary block. Then you have pupillary block happening at the level of the iris. Behind that lies the lens, the ciliary processes and the vitreous. So anything that is behind the iris will always have a component of pupillary block. That's the rule. And this is something that is described very well. So that is why in malignant glaucoma, the PI will help a little bit. That is why you need to do it first. That is why in even phacomorphic glaucomas, if you do a PI successfully, you will get a significant drop in the pressure. So
but I think his question is, in a non-pupillary block glaucoma, will a PI help?
So there is no pure non-pupillary block glaucoma. The only ones are like neovascular glaucoma, anterior pulling mechanisms, IC syndrome.
Yeah, there is this entity of thick peripheral iris roll, thick plateau iris, thick peripheral iris roll. Again, because the thick peripheral iris roll is actually non-pupillary block, but there will be some component as the patient increases in age. There is some, those thick peripheral iris, you cannot do a PA. So you have to observe them serially, and if the lens increases in vault thickness and the chamber shallows, then you have to attempt a PA. We had recently a patient who had a thick lens, but we couldn't do the PA, so we had to do a surgical PA for that patient. But pupillary block will invariably be there as the patient increases in age.
And for this, yes, plateau iris also, we routinely advocate a PI, but we must do a gonioscopy after that to rule out whether there are persistent areas of iridotrabecular contact. And in that case, this 360-degree peripheral iridoplasty helps.
But LPA is not indicated, so do LPAs in plateau iris also?
Because it's at the level of the ciliary processes. Below the iris, there is a component of pupillary block.
And sir, SLT pigmentary glaucoma in young patients also it works well?
So pigmentary glaucoma in young patients, for example, the patient is, let's say, around the age of 42, 44, we use less energy. So we reduce the energy from 1.1 to 0.9. If it is an older patient, we increase the energy. So pigmentation will cause a better response. So for that, we reduce the energy and do it. So more pigmentation, you have to reduce the energy. Young patients with less pigmentation, you increase the energy slightly.
Yes.
If I gather the indication for the PI in pupillary block, if the iridotrabecular contact is more than 180 degree, even on indentation?
No, without indentation, if you
without
see that...
indentation will change.
No, but if
without
indentation opens up the angle and you can see, then you don't do it.
No,
you
no.
have to do. That's occludable angle.
That's appositional. Yes.
Like we were discussing, sir, though the ZAP trial says that there will be less conversion to PAC than what we thought it would be, but everything would depend on the compliance of the patient sitting in front of you and the risk factors. If the patient needs a lot of dilatation for a diabetic retinopathy or has a family history of glaucoma, whatever risk factors, and first is the compliance, whether the patient will keep coming to you regularly for us to note any change in angle status. And any case that we are thinking of observation, it should be a joint decision between the patient and the doctor that yes, you are going to be under observation. Because if they go into acute attacks, they can come back to you with a legal procedure also.
Because studies by Dr. Ramanjit Srihota and Dr. Ravi Thomas, progression of PACS to PAC and PAC to PACG, they are much higher than those noted in the ZAP trials. So Indian context, probably you should definitely do a PI when you come across either appositional or synechial closure.
Both of them have recommended not to do PI.
Again, both of them have recommended not to do PI.
No, we look very clearly at our center in Hyderabad, we don't do PIs for PACS. But when it's a matter of patients who are come to our secondary centers, the rural setup, the clear guideline is the moment you see an occludable angle, do a PI. Because those patients come from such remote areas, they are not going to come back. And if you train people well, they will do PIs safely.
Dr. Arijit, please.
Yeah.
Thank you, Dr. Siddharth.
So the diagnosis part is already complete and the surgical part is already complete. So I think nobody will be interested in the medical management because it's the least important part. We need to diagnose and we need to do surgery. So nobody wants to treat. But let me go ahead with my presentation. It's the role of medical management in PACD from pilocarpine to PGA. So I'll start with pilocarpine. So this has been the scenario for the past 6 months to a year. where every site you go to, be it 1mg, be it PharmEasy, you see pilocarpine is sold out or out of stock, or you go to the medical shops, they are not there, patients are calling you. However, the things have changed drastically over the past few months. Pilocar is again going to be available, and certain newer drugs like Pilokite from Kamla Life Sciences is already available, at least in centers in Calcutta. So things are again looking up. Now, why do we need a drug like pilocarpine? The answer to that is myotics are the only medication which have a mechanical effect on the conventional outflow pathway. So they are the only drugs which have a mechanical effect. Now, why is that important? So I want to quote a few studies which have been done on genomics as well as ultra microscopic studies which state the following. Number one, the aqueous humor supplies antioxidants, growth factors and nutrients to the trabecular meshwork outflow tissues. A. B. Drugs which suppress aqueous humor production and or enhance uveoscleral outflow, which is basically all the other drugs, they decrease the aqueous humor supply to the outflow tissues. So what does that do? It causes nutrient deprivation to these tissues in the long run, and so greater than normal degradation of the trabecular meshwork occurs, and you are causing more damage and more risk over time. So I just wanted to throw in some controversy. Rest is up to you. So basically all the drugs that we are using to treat open angle and angle closure glaucoma probably in the long run may be doing greater harm than good. Therefore, we definitely need drugs like myotics which have no effect on the reduction of the aqueous humor or the uveoscleral outflow. However, there are certain situations where we should not be using pilocarpine, like in patients with phakic IOL. So this was a particular study where the patient had a +7 diopters in the right eye, +7.1 in the left eye. Post phakic IOL, the surgeon gave pilocarpine to accelerate the recovery, and that caused a phakic IOL lenticular touch which caused cataractous changes. So probably in these cases, do not use pilocarpine because this vault is going to reduce. You need this vault to prevent the contact between the phakic IOL and the lens. Now, there is a problem with pilocarpine, and the studies done on aging rhesus monkeys. So there are no human studies as such, but there are umpteen number of studies in rhesus monkeys which show that the pilocarpine induced responses of the ciliary muscle and outflow facility, they decline with age. So that may explain the reason why some of your patients, they were on pilocarpine or Tumolol and pilocarpine, they were doing pretty well, and after 10 years suddenly now the IOP starts to rise. So these studies can probably explain, and like I said, it's not one, there are a number of studies which state that the contractile response to pilocarpine diminishes with age at a rate which is similar to that of accommodative decline. So maybe you're treating the patient, you are getting a good response, but over time you'll see that the response wanes off. So this is to be kept in mind. I want to shift on to the next group of drugs, the ROCK inhibitors. Now, why did I put the ROCK inhibitors after pilocarpine? Like I mentioned, pilocarpines, they have a mechanical effect on the conventional outflow, whereas ROCK inhibitors, they increase the conventional outflow through the trabecular meshwork and the scleral spur. However, the mechanism in which they do it is different. They alter cell contraction, cell motility, they cause cytoskeletal rearrangement, cell adhesion, remodeling of cell-to-cell contact, alters the episcleral venous pressure, etc. So ROCK inhibitors also are the only drugs which act on the conventional outflow pathway. So all the other drugs, they have no effect on the conventional aqueous humor outflow. So probably this is a niche product and should be kept in mind. Now there's a problem with both ripasudil and netasudil. That is, all the studies are on open angle glaucoma and ocular hypertension. So there are no studies on angle closure glaucoma. However, we have been using it since pilocarpine was not available. I shifted a lot of my patients to ripasudil and I've got pretty good results. So probably there is definitely some role. And some of these studies, like this particular one, it says that there are some pleiotropic effects of ripasudil. Pleiotropic effect means it's not the main effect, but certain other associated effects like neuroprotection, increased ocular blood flow, anti-inflammation, anti-scarring, decreased macular thickness in eyes with the DME, and corneal endothelial cell effects. Obviously, the corneal endothelial cell effects have been very well publicized. So in angle closure patients where the chambers are shallow, probably post-surgically also ripasudal or nitrasudal may be used. Also, there are some interesting studies which conclude that ripasudal can be a trabeculoplasty outcome marker. That is, presence of a ripasudal effective eye appears to significantly predict the success of trabeculoplasty. Now, trabeculoplasty is usually done in open angle patients. However, efficacy of SLT in primary angle closure glaucoma has been shown in certain studies. So I'm just playing the devil's advocate. There are no studies on angle closure, but probably it may have a role. Also, ripasudal has been proven to be a trabeculectomy outcome marker. Again, in open angle glaucoma cases, but playing the devil's advocate, maybe it has a role in angle closure patients also. This particular study showed that ripasudal has got a very good effect on uveitic glaucoma patients. So there is a greater than 60% reduction in the number of patients, 40 to 60% reduction in the number of patients, 20 to 40% reduction. That is overall 70% reduction of IOP in uveitic glaucoma patients. So uveitic glaucoma patients have a lot of pus, they have a lot of pigments. So probably ripasudal will have some effect on angle closure glaucoma patients also. Coming to brimonidine, now brimonidine decreases the aqueous humor production, facilitates UV scleral outflow. And there's something very interesting which happens with brimonidine. It has a miotic effect. Therefore, it is used to prevent glares and halos and reduce visual aberrations after refractive surgery. So, it does cause miosis, but does it cause changes in the angle? And this was shown by a study by the Corantes group, which showed that even though brimonidine has a miotic trend, it has no significant effect on the anterior chamber angle in patients with narrow angles. However, do we need to use brimonidine? Yes, Dr. Ganesh Sir has already mentioned pre-procedure before a PI, post-procedure to prevent the IOP spike, we do need brimonidine in angle closure glaucoma patient. Coming to brinzolamide, how many of us use brinzolamide in angle closure patients? A show of hands. Do we use brinzolamide? No one uses brinzolamide. We all do, all of us do. But there are these studies by Chen et al. Which show that in the acute phase, brinzolamide did not improve the effectiveness of the sequential treatment. Also, if you look at the summary of product characteristics or all the literature which is supplied with the drops, they say brinzolamide has not been studied in patients with narrow angle glaucoma and its use is not recommended in these patients. But don't follow it, we all use it and therefore it gives pretty good results. However, it's not backed with evidence. We do find that there are excellent results. Coming to dorsolamide, again, dorsolamide has been shown not to have excellent effects because latanoprost monotherapy, as was shown in this particular study by Sakai et al., was more effective than unfixed combination of timolol and dorsolamide. So probably it should be used but as a second line because prostaglandins have emerged as the first line. Timolol, we definitely use timolol, and according to some studies, timolol has more effect in post-LPI or post-surgery. And timolol plus pilo is better than timolol alone. However, again, latanoprost was more effective than timolol twice daily. I will end with prostaglandin analogs which have now emerged as the first line management in any form of angle closure. So the meta-analysis studies show that latano, travo, bimato all provide significant IOP lowering efficacy in eyes with angle closure. The efficacy is not affected by degree of angle narrowing or extent of pus. There are multiple studies on this. Both latano and bimato significantly reduced IOP in CACG patients who were inadequately treated with LPI. That is, post LPI it is very effective. And in cases with 360 pus, is it effective? The answer to that is yes. There was significant reduction in IOP in CACG patients even with 360 degree of pus. So in an acute attack, probably the drugs we need to use are beta blockers, alpha agonists and PGAs. What is to be looked into, I'm not mentioning the newer agents, but probably the miotic which act only on the pupillary sphincter but not on the ciliary muscle needs to be looked into. Brimonidine in angle closure needs to be studied, and how PGA works in fully closed angles needs to be studied. Thank you so much.
There is going to be a thank you, Orijit, for a very comprehensive informative presentation as usual, but now we are running short of time because some other program will be taking place in this hall after this, and so I will move on to the next presentation. And just a synopsis of PACD and some case-based discussions. So PACD is a spectrum, and gonioscopy is the crux for diagnosis of this spectrum, and management of angle status is the main treatment strategy, IAG-PI being the usual first line of intervention. Subsequent interventions may be iridoplasty, cataract surgery, trabeculectomy, phacotrabeculectomy, and anti-glaucoma medications. So PSCS and PSC cases, we normally do a PI, whereas if iridotrabecular contact persists in cases like plateau iris, we normally do a 360-degree Argonne laser peripheral iridoplasty. This was a case which was status post-angle closure attack, and here we have thick iris with atrophic areas, barely any crypts, shallow AC, glaucom flecken, and in this case we managed to do a IAG-PI, which is not always possible in these cases, and then with the help of anti-glaucoma medications including pilocarpine, we were able to quieten the eye, and the angle has opened up in a lot of places, and there are only scattered areas of PAS, and the patient is doing well. But in all PSCG cases, we cannot control them with IAG-PI and anti-glaucoma medications, and then with trabeculectomy, we are able to control most of them when there is no significant cataract. And any trabeculectomy is augmented with mitomycin, and now we are trying to shift to intratenon mitomycin over the proposed area of trab, and then continue with the trab procedure. Involved where in PSC cases where lens fault is also a cause of pupillary block, cataract surgery is mandated because it helps to deepen the angle and deepen the chamber and widen the angle. We have to do a medium length tunnel, give liberal use viscoelastics, more cohesive viscoelastics, do optimum size side ports so that the anterior chamber depth is maintained. And while we do a rhexis, we should do it carefully, because in these vaulted lenses there is a chance of runaway of the rhexis, and then we proceed with phacoemulsification as usual. In this patient with PSCG with significant cataract, the best way to do surgery is to combine a phaco with a trabeculectomy, and we can do it superiorly, same site, different site, or a superior trab. As in this case, I prefer to do a superior nasal flap and then proceeded with a temporal phaco, because there was AC was very shallow superiorly. And in these cases, Phenocane Plus is a very useful drug in our armamentarium, produced by Entod Pharma, which has tropicamide, phenylephrine hydrochloride and lidocaine, and helps to stabilize the pupillary dilatation. So we do our phaco and then we proceed with trabeculectomy. But in these chronic ACG cases where the IOP continues to remain raised, the eye remains congested, there is corneal edema, we cannot lower the IOP, we need to go in surgically to reduce the IOP, but we must do an optimum wet field cautery before we fashion the trab flap, because otherwise we may have blood-filled blebs which do not do very well. So we do an optimum cautery before we fashion the flap. And we must make a very shallow graded entry into the AC, releasing the IOP slowly, as these eyes are susceptible to expulsive. We often have compromised pupils, not dilating due to posterior synechia or rigid pupils, and there these pupil expanders have really improved the outcome of these surgeries. The B-hex ring is a thin, flexible, hexagonal polyimide ring which has no joints, can be easily applied. It has a forceps of its own by which we can introduce the ring. And if AC is very shallow and the ring is thin, this is very useful. It gives a dilatation about 6 millimeters. And last but not the least is the Malugin ring designed by Boris Malugin, which is a sturdy ring, gives about 7 millimeter dilatation, and again is a very useful in PACG cases to give us very good outcome after surgery. Thank you. And we are acutely running short of time. So thank you, my co-instructors, and thank you, audience, for your patience hearing. Thank you so much.